just to show a slightly different aspect of nailing. So this was, I'll show the one case because I've seen her for a longer follow-up, which was fortuitous because she came back for another reason. So she was about 70. She'd fallen, she'd got an open peel-on fracture, and she was diabetic. And so that's the plain X-ray. She was taken to theatre by a colleague, and you see she's got a spanning fixator on, and at that point there's gentamicin beads sat in the open fracture area, and she was waiting a secondary procedure. So discussed it with her, and what I was concerned about was her getting a lot of stiffness afterwards with her diabetic foot, because if her weight bearing on her foot was uneven, then it was likely to get problems with the sole of her foot. So wanted to try and maintain movement, but on the other hand, you clearly weren't going to maintain much of the ankle movement. So nailed it from above, nailed it, and that's an arthrodesis spike, a pseudarthrosis spike going into the talus, found the entry point into the talus, and then put the nail right down into the talus. And with the, fortuitously, with the Synthes nail, whichever side you use, right or left, the oblique screw, because you can get distally, will go along the length of the talus. And so locked it distally. That was when we did it, you can see it's crumpled up, shortened it a bit so that the soft tissue's closed, and she went away. And then she turned up several years later, and that was sometime afterwards. And she'd arthrodesed, she'd been mobile on her foot since. She still had some movement in her subtalar joint. I've rogered it a bit, as you can see, but it's not bad. But I think that one of the things that struck me about it was I've had hindfoot nails fail, and I suspect is that the patient has lost all shock absorption between the floor and the first coupling of the nail to the bone, because there's nothing protects the os calcis. Whereas as soon as you've got you keep the subtalar joint, there's a little bit of movement before the load's transmitted to the talus onto the nail. And I think that shock absorber perhaps preserves the fixation down there a bit longer. So on a series of 1 in an elderly patient, it did work. So I thought I'd show you that one case.
Thanks a lot.
Thanks very much.
Yep. Have we got any questions to open the batting? Can we maybe let's go back to the whole issue perhaps that we started out with and talk about ankle fractures. Maybe a show of hands. How many people commonly plate a posterior malleolus? Hands up. Oh, quite a few. How many people never really plate a posterior malleolus? So it looks like there's lots of plating. Tim, any comments about this trend towards posterior plating?
It's a very gratifying operation to do. There's something about taking a V-type shoulder fracture, exposing it, seeing the causal edges, reducing it anatomically, and squeezing it with a plate, and so I can immediately accept from a surgeon's point of view. It's a very attractive procedure to undertake. Thank you. However, it does require that change in positioning, it requires that larger exposure, and it does come with dangers as a consequence. And when there is a simpler, easier, smoother, and I think probably safer technique that has outcomes that are just as good, it seems that that's probably a step that we should be thinking twice before taking.
Bob? Yeah.
To me, this brings up an interesting point, and I would have issue with one of Nigel's slides for the same reason that Mick Pearson mentioned it. So it was written up there, the principles of managing this injury, as if they're immutable. So the principles were we had to restore the joint, we had to get movement, we had to do that, as if that's and they're concepts, they're reasonable concepts, and they're reasonable as long as you're prepared to question them. Mick was prepared to question them on the basis of external fixator studies for Pelon, and what you're saying is that you should be prepared to question them. So then, as soon as we give something the status of a principle, it means that really whenever we can achieve it, we're duty bound to, and I think that's what's happened. You see posterior malleolar fractures there. You know you've got the techniques to put it back where it came from. Therefore, we should do it, because we've got that deeply drilled into us that it's a principle. It's not just a concept that it might work for a particular group or a particular type of treatment. And I think I've been as guilty of that as most with long association with joining things together precisely. But I think you have to be careful that you don't give things a status of being irrefutable when they don't necessarily deserve it if you look at the evidence.
Great, thanks a lot. Richard.
I fix quite a few posterior malleolus fractures, but I fix them when I feel it's indicated in that I think we tend to forget that we need to look at the initial patient and the initial x-ray. For me, if I see that the talus is sitting out the back, irrespective of the size of the posterior malleolus, I know the soft tissues are a problem. And I know that if I address that, I have some chance of getting it right. But you can't do it in everybody. And if you have an elderly patient with a complex fibula, you can't do it from the back. And in that situation, I will either say I won't address the back, I'll fix the fibula as well as I can, and then address the syndesmosis. I'm not sure the whole significance of contact stress. I don't think that's particularly the concern. The concern is stability more than anything.
Any comments from any foot and ankle members of the audience? Bill?
Well, I mean, I don't fix every posterior malleolus, but I've got a fairly low threshold, as Tim Chester will tell you, because we have the discussion most mornings at the trauma meetings, and the rule of thumb we have is if I can see from the back of the trauma room on the x-ray screen that there's a posterior malleolar fracture without my glasses on, it probably needs fixing. But the more serious point is that if you CT scan these, somewhere in the region of about 80% of them, I reckon, have got a fragment of bone that's sat in the fracture site. And you can't always see that on the plain films. And that is also something that's very, very difficult to get out of the way in order to reduce the fracture if you're going to fix it from the front. And as a foot and ankle surgeon, which again is something that I keep telling Tim, is that the problem with these, the ones that do cause trouble where they're subluxing out the back, which is not always easy to tell at day one, they're the ones that come back with ongoing pain 2 years down the line, and at that point it's very difficult to deal with it.
Right. I mean, what percentage of them do you get scans on then? All of them, or?
Well, we most of our patients seem to have CT scans as they come through the door. But I personally have got a fairly low threshold, as Tim will tell you, for getting CT scans on these, because you often get some nasty surprises.
Okay, we got Sonnet up at the back here. Can we toss the cash box back to Sonnet? Just keep your heads down.
Thanks. I just wanted to say one thing about Tim. Overall, I think the posterolateral approach is more soft tissue friendly compared to lateral plating. I do it only in cases where it's really badly displaced and it's a big fragment, but there's no metal work underneath the incision. Of course, it's not as friendly as a fibula nail. I'm a big fan of fibula nails, but if you're going to plate it, I think if you go from the back, you can address the posterior malleolus and the lateral malleolus, and the incision is not over the metal work.
I think it's some other, yeah. Comments, can we just toss it all the way?
Very short thing. I don't think the plate has to be a plate. So for that reason, I don't think you can track as blue.
Alex.
We're all talking about the differences in hardware and so on, but these fractures, there's a whole plethora of things that are going to influence the outcome, from the way you handle the soft tissues. We've seen clips in the wounds and those sort of things. What I'm intrigued is how many people are still using a tourniquet to fix any of these if they're opening them, because I personally think that the tourniquet has a big impact on the tissue ischemia, the wound healing, and the risk of wound breakdown. So I've abandoned it completely for all surgery, but I wonder if people are still fixing ankles using the tourniquet.
Show of hands, all people for routine ankle fractures, tourniquet usually on. Yeah, it looks like most people do, yeah.
Tell you, stop it.
Okay, I mean, do you Charlotte, yeah.
You can come back to the tourniquet. I'm still unsure about the hindfoot nail and the fibula nail. So, Bill, you're saying that you can't distinguish between the pilon and the unstable ankle. Tim, you're saying the majority you can fibula rod, but there are a small group. And also, there's a few things. I really do need to clear this up. And it's partly because I think this is the problem when you've got trauma surgeons and you've got specialty surgeons, is the foot surgeons discuss things in their meeting, they then come back and then they tell the trauma surgeons, no, this is what is the gold standard, and we need to kind of have a unified approach. So I'm told by my foot surgeons, yes, you can use the hindfoot nail for your bad elderly ankles, but you've got to prepare the joint surface, otherwise it will fail. The hindfoot nail is not for ankle fractures, it's for fusions. And so I'm then confused because I don't go to BOFAS, limited study leave and all of that, limited study leave. But it is a difficult problem because apparently, and I've looked for the paper, there is no paper, it was presented at BOFAS, a guy called Sharp from Exeter, you've got to prepare the joint surface. So I'm really interested to know, do we?
So a comment from the BOFAS recruitment committee here on my right-hand side.
It's, to me, when you're dealing with foot and ankle trauma, you look at, there's various papers down the various parts of the foot and ankle that talk about essentially using a trans-joint method of fixation, Lisfranc. And you get studies that say, well, there's no difference between primary fusion and just putting metalwork across. And everybody says, well, why not do a primary fusion because then you don't have to do a later fusion. But it misses the technically difficult point, which is that actually by preparing the joint, you actually increase the instability of the injury that you're dealing with by definition. And okay, in our series, we've seen no evidence that you need to primarily prepare the joint. What you need to do, and this is something that is a clear message, you do need to make sure your fixation is appropriate and that you're using the damn thing properly. And that, well, that one you showed. Oh, okay, fine. Putting the thing through the fibula, by definition, gives you another unstable segment. The distal screws, the biggest area of good quality bone we know from calcaneal fractures is the sustentaculum. So if you get a screw that's going into there, in the calcaneum, then you're going to get better purchase, better fixation. And okay, fine, in our original design nail, we probably made a mistake because we made 2 transverse screws, but having another screw at 90 degrees to that, so you can use the posterior process of the calcaneum as another good quality bit of bone. But you have to make sure that you place your screws properly, make sure that they've got a good grip on bone, and then you don't see some of these problems of screws backing out and so forth. But the idea that, as I say, that you add a further insult to what is a complex injury in the first place by preparing a joint to do a primary fusion, I just think it's just not necessary. It just increases the instability of that injury. Going back to the posterior malleolus, just very quickly, how many people in this room think that fractures that involve a significant, and you can ask the definition of that, posterior malleolus have a good prognosis for the patient?
If properly fixed.
But that's the question, isn't it? So actually, when we see that as an injury, it's a bad prognostic sign. Mm-hmm. And what we have to look at is not what results are a year down the line. We have to look at 5-year results, and we have to look at those patients who develop arthritis. And the factors that probably influence arthritis are the primary injury that damage the joint surface primarily, the reduction and the stability that allows you to try and change the nature of that primary injury. And the question I would have for Tim is, when he's fixing from front to back, how do you check your reduction? Yeah, okay, fine. So, okay, how often have you done a CT of that post-op? Okay, I suggest you start doing that a bit. Now, I'm not being funny. I actually don't think we know whether putting back to front screws or front to back screws or plates, we don't know actually what controls this situation best, and that needs further proper studies and maybe, where's Matt, randomized controlled trials to show it. But what we need to do is to make sure that we're checking our reduction properly, because that is one of the factors that will produce joint incongruity that will then lead on to post-traumatic arthritis. So that's the question, is are we establishing that we're actually treating the damn thing properly? And I don't have a problem with the idea. I must admit, putting a screw in front to back is a little bit like putting a nail through a wall and hanging a picture on the hooky bit on the back on the other side of the wall. Potentially. It's more difficult to be sure that you've actually really got good control of that fragment. Maybe. But it doesn't matter what I feel about it. It needs science behind it. But we have to make sure that we're reducing the thing.
Right, can I bring somebody else in? Yeah, just.
I see a little conflict there, Ian, because on one hand you say there's a bad prognostic sign and that uncle is not going to do very well probably. And then you say, well, we probably should go for anatomical reduction. You should check your reduction on CT and things. No, I'm not saying you say that, but perhaps it doesn't matter. The little incongruity which Tim achieves with his...
A slight point I'm making, in a way, is that what you need to know is what you've done and then make proper comparators. And if we are not getting good results out of this fracture pattern, we have to then challenge our thinking about how we produce. It's not about just measuring what we do now. It's about looking to the future and how do we improve. It's a quality improvement program in those terms. We have to decide how we move forward from where we are at this point in time and what factors we can use to influence that.
I'm going to take Andy and then Bob, I think. Andy,
It was just on a different point, and it was more just asking how you're assessing the syndesmosis. You've got a patient prone, so one of the advantages of fixing the posterior malleolus is that you're reducing that, or stabilizing the syndesmosis. You can also plate the fibula through the same incision or posterolateral, but how are people assessing that? It's something that I'm not sure about in terms of the syndesmosis.
What do you mean if the patient is in the prone
Well,
position?
if you've reduced the posterior malleolus and fixed it, you've in a sense stabilized the syndesmosis, I think. It's my, and are people, how are they assessing it? Is it changing their management of syndesmosis injuries, the fact that they're plating the posterior malleolus more frequently?
Comments on assessing the syndesmosis? Anybody? Yeah, Nigel? I know actually in relation to position that at a meeting I was at in the RSM last year, Anthony Ciliarco made the point that you don't have to have the patient prone to do this. He puts them in a sort of a floppy lateral position. So he puts them in the lateral side and the posts are up here so you can tilt the patient. So they don't actually have to be completely prone. So it's feasible to do it without having the patient with all the disadvantages that Tim was talking about. Nigel?
I hate to be controversial again, but I don't think you can make the decision of fixing the syndesmosis on the table. I think that's a preoperative decision. The decision to stabilize the syndesmosis is not made on the table. If you've looked at those preoperative film CT scans and you think there's a significant syndesmotic injury, you fix it, you stabilize it. And that's not an on-table decision.
My experience, and the floppy lateral, which you described, we wrote up a few years ago, and it's definitely a benefit because you don't have to have the patient prone with armoured tubes, and you can also bend the knee up and get at the front if you need to. I would argue that most of the posterior malleolar fractures, even quite a small fragment, if you're going to go in and fix them, by the time you've fixed it, you've stabilised the diastasis anyway, which is what you were saying, I think. And if you make your incision fairly tight on your Achilles, so you make it more towards the medial side, you can pretty well get right across to the tib post tendon medially, and you're also coming down right on the fracture. And if you make your incision in the standard posterolateral, where the books describe, you come down on the back of the fibula, and then you struggle to get over to the medial side, and you're using your retractors and things to lever the skin, and that's when you get wound problems.
Bob, did you want to make a point, I think?
How many people can put on a close contact cast? Who's done them according to the... Yeah, it's interesting. The numbers are not that great. I mean, the AIM study's now out in JAMA. It's been around for a little while. Charlotte, I know, has mentioned that the follow-up was not lengthy, but there will be longer-term follow-up in that. That is a big group, and the longevity of the patients is not that great. So the shorter follow-ups may be appropriate. We'll see what happens, but certainly, I think we should all be capable of managing a fracture in a modern non-operative way. And the evidence that came from the AIM study is that for unstable ankle fractures in the over 60s, 4 out of 5 can be managed adequately in a cast. 1 out of 5 can't. And so that's quite a good thing to discuss with the patient.
Can I just ask, Bob, I mean, in the AIM study, who was putting on the plasters? I mean, was it
So the AIM protocol was that it was put on by somebody who'd been taught how to do it. It was put on under an anaesthetic in theatre.
Yeah.
And it was done by the majority were done by the surgeon. A technician may actually have applied the cast if you'd done the reduction, but in the majority it was done by a surgeon.
There's not a lot of surgeons skilled in modern practice in putting on
That's
casts.
why there was that's exactly my point that I'm making, is that we're drawn in a position where we feel that we're skilled at operating.
Yes, yeah.
And so we don't then consider the other options, but then we then say that we're not entirely sure of the outcome if we don't do this or if we don't. So I'm not wholly advocating. I operate on a lot of fractures, but I think we have to keep our minds open to the fact that we may operate on some that we don't need to.
Yeah.
We most certainly do. You want to throw that back?
Yeah. Okay, I've got some people from the back, and we haven't had Chris yet. So can we toss that back in the direction of Chris Moran? Not too hard. He's very eminent now. So.
Can I ask for an honest show of hands? The AIM study, the ankle fracture study, has it really changed your practice, or have you continued what you're doing before? So who has it genuinely changed their practice? Okay. So for the researchers, that's a very interesting finding. You need to think about why it's not changing practice.
Oops. Yes. If in doubt, always operate. That's my philosophy.
No, it's all right. Okay.
Anybody else want to come in? Yeah, we've got I'll come back to you, Tim. Can I give this to the gentleman at the back here?
Very short question. RAF versus nail fusion. RAF fusion.
RAF fusion. Anybody want to comment on RAF fusion?
I've never failed RAF.
What's that? No, but the RF fusion, I'm sure you all know what it is, but you're taking the distal fibula off and then fusing it and then tacking your fibula back on. Yeah, yeah. No, I mean, if most of the formal fusions that we do in Bristol, we do arthroscopically. And if you take, obviously you don't need to take the fibula off to do that, and if you do, you're destabilising the situation. So I'm not saying the RAF. You can. For what? What are we? For what though? For arthritis. Yeah.
That's what I need in my practice. An operation that's 100% successful, irrespective of the indication. That's important. Right, Tim was wanting to come in here. We've just got a few minutes left just before coffee, so.
One of the factors that might limit the uptake of AIM is perhaps that Bob, the headline result was that 4 out of 5 was treated successfully and 1 out of 5 had to be converted to fixation. But that ignores the sort of awkward point that another 19% of them had to go back to theatre for remanipulation. So actually, is that not right? The failure rate was something more like 1 in 3 or just over 1 in 3. And that's a substantial spin of the dice if you're looking at choosing your treatment options. That's a perfect option if you want to get it right second time.
So I think that's a fair thing to say, but that's informed consent. So you give that as an informed opinion to a patient and then let them make their judgment. Because one of the things that was interesting when the study was going on was that patients responded differently to whether they were randomised to operative or non-operative. Some were clearly disappointed that they'd not got an operation, whereas some were clearly delighted that they'd avoided the operation. And I think patients would respond to the information that you gave to them. But one of my contentions is that the way we put information to patients is not unbiased by any stretch of the imagination, and that you're biasing it because you're a surgical fixer, and so am I. I mean, that's the background I've come from, and I know, and it's difficult to say it. And in some respects, I don't like standing against the group that want to put metal in, because I'm a craftsman. I can bend bits of metal as well as the next. But patients, I think, deserve to be informed, and I think that means that we should be aware of the results. And you can treat 4 out of 5 patients satisfactorily. There'll be ups and downs, but you can treat 4 out of 5 satisfactorily.
Let's have a final comment from the man at the back. Can we just hand this to you? So one more comment, and then we're going to break for coffee. Thanks.
I mean, I think everyone's got a valid point here, but it's interesting you talk about results and consent. Why are we all trying to hone this down to a rule? You know, to my mind, trauma surgery, the beauty of trauma surgery is every case is different. Fracture's different, soft tissue different, patient's different, the ability of the surgeon's different, implant's different. When we're consenting, should we not be saying, well, in my hands, with this injury, my technique, these are my outcomes? If that's my injury, I'm going to sit and ask the person who's going to do my operation what the results are. And I'm not sure why we're all trying to focus on one protocol for this. You know, should we not be being specific about the injury and our ability for that patient? You know, I don't understand why we're trying to reduce our individual skills and abilities.
I think that's a very valid point, and a very good one which to end, because if we open up the issue of informed consent and the pros and cons, we'll probably be here for the rest of the entire meeting. But thank you very much. We're going to break up for coffee just now. Thank you to the speakers for their contributions, audience for your contributions. Thank you to the speakers for keeping on time.